We talk a lot about how to implement the lung cancer screening program, and now I'm going to focus just in Lung-RADS and what you're going to encounter once you start reading these CTs, because just like Dr. Goodman said, Lung-RADS is just the first of the iterations of that we're going to have, but that's probably going to evolve, and that's going to happen based off what all the problems that we are encountering as we read it. So I'm just going to present cases that we have, and I'm going to show you how we've handled it. And based on our collective experience at UW, we also email a lot of our colleagues around the country just to ask them, hey, I got this nodule, I don't really know what to do with it. It's not really clear in Lung-RADS what to do with it. So I hope this is helpful for you in the future once you start reading these CTs. So I think we went already through the background, but basically Lung-RADS was developed by the ACR to meet CMS requirements, and we just want to do the same thing in a consistent manner. So it's just a way to get standardized reporting and management for all the nodules that we see. And it's a good tool because it's going to let us know in the future how we're doing and are we really benefiting the patients and how can we improve that. So again, this is the famous Lung-RADS. You can't read this, that's not the point. We don't know it by memory, we just print it also and we have it next to our workstations. But what's important is that it's based on BI-RADS, which we're all familiar with. And you just localize your findings and in your impression, depending on what you're going to do with your template, but basically in your impression, you want to give it a number and a management option, not just a number. You have to tell your physicians what to do with these nodules. And the higher the number, again, the more worrisome the finding is. And we'll see through some cases what to do when things don't really match. So screening, we kind of went through it already. It varies. Tons of organizations advocate lung cancer screening, and they all have different really options. And this is going to probably evolve in the future, but beyond the scopes of my talk. So I'm just going to present you cases, as I said, and see what happens when we don't really have clear answers. So for example, if you get an 80-year-old person, that's the USPSTF limit for lung cancer screening. What happens if you find a new nodule in a person like that? According to Lung-RADS, this is a category 3 nodule because it's new, and according to the size, it just falls under 3. And your recommendation is to follow it up in 6 months, but in 6 months, the patient is not going to be eligible for screening anymore. So what to do in those cases, for example? I mean, you can put in your impression it's a Lung-RADS 3, or you can just put it's a new nodule. But you should talk to the clinicians and tell them what to do. And unfortunately, they're going to call you back probably like, hey, they're not eligible anymore. What do I do now? Well, you can still follow these nodules as non-contrast chest CTs and keep your Lung-RADS recommendations because they're the least of aggressive recommendations compared to Fleischner. However, we all know that these patients at 80 and they have tons of comorbidities. So this is your chance to talk to your clinicians and tell them, hey, this is new. This is what Lung-RADS recommend, but talk to the patient and see if whether or not she or he will be amenable for treatment should something happen to this nodule. But just don't leave it blank because this just causes more confusion and people to hate Lung-RADS more than they should. I mean, this is just trying to help patients. So another question we get asked a lot is, what do you do when you phase out of Lung-RADS? Do you go back to Fleischner? Do you keep using Lung-RADS? And the answer is, Fleischner societies were developed in 2005 based on all data. And they're pending review at some point, but they were done just for incidental nodules done not for lung cancer screening. If you have a new nodule, you should not be using Fleischner society guidelines. So anything related to lung cancer screening, you should be using Lung-RADS because it was developed for that. It's based on all the data from the lung cancer screening trials, and it addresses new nodules, changing nodules, and the recommendations are usually a little more spaced out. Now we're kind of giving it a little more time for the people to, when we recommend follow-ups for the nodules. This is another case we had, and we found a nodule in a baseline screening. And it was 90 millimeters in diameter, as you can see here. And luckily, we had a CT from the abdominal pelvis that went up enough that we could see that nodule was there 12 years ago. So we all know that this is not a lung cancer. I mean, lung cancer just doesn't sit there for 12 years. But what do you do with this nodule, and how do you categorize it according to Lung-RADS? And once you print your table and start looking at Lung-RADS, it really doesn't address things that were there before the baseline screen, actually. It just doesn't talk about it. So you're kind of stuck with that. And one of the interesting concepts that we use and that we hope we keep using in the future is just not checking a nodule based on its axial diameters, but the volume, because it tells you a lot about the behavior over time. And this is a calculator that I use, but there are many online of volume doubling times. And if you plug in the numbers and the data, that nodule took 5.2 years to double its size. And usually we consider benign a nodule that doubles the size over a year, 0.2. So this is like 5 times that. We know that's not a lung cancer, but Lung-RADS just doesn't let you compare to something that was there before. So technically, because it grew from whatever prior we have to give it a category 4B, which is basically telling that patient that they have more than 15% risk of having lung cancer, which causes anxiety, of course. And we know this is benign. So at this moment, we're kind of stuck, but possible solutions is that in the future, the baselines are going to be addressed in Lung-RADS, and we are able to use volume doubling times. There is also something that, this is a PET CT that was done. Of course, it was negative, not really necessary, very expensive. On the meantime, you have a little thing right here next to the 4B category, which means the recommendations that you can give: chest CT with or without contrast, a PER CT, or tissue sampling depending on the probability of malignancy. And if you go down to the very tiny notes at the end of Lung-RADS, it says that you can give management based off your probability of malignancy. So this is your way out of being a doctor and say, hey, you know what? I don't really think this is a cancer. Why don't we do something a little less aggressive, follow it up in 6 months or a year, depending on what you think. But this is a way of Lung-RADS are suggestions of how to handle things, but you don't have to get stuck in it if it doesn't really make sense. And you're gonna see that as you keep using it. So the footnotes sometimes save you some time, and that you'd be a little more flexible than the table looks like. So this is what I was mentioning. Nodules that are solid with volume doubling times are usually benign when they're bigger than 400, when their time doubles more than 400 days. And we all know that that was probably either a granuloma that never calcified or a mesenchymal tumor that just didn't have the typical features. So if you just follow it up in 6 months, it will go back to category 2. And basically, I mean, you're not going to give it a negative, which will be great, because if you know that that has like the central popcorn or the fat, you're just going to call it negative. But the management is not going to change. It's going to be the same. It's going to be a follow-up CT in 12 months. Now I'm going to talk a little bit about subsolid nodules, and we've learned about those a lot in the lung cancer screening trials. And they classify themselves in pure ground glass and part solid, which is a little bit of ground glass, and this is the same nodule. You can see it has a little tiny solid component there. And they're tricky, they're hard, they're very irregular, they're hard to measure. Even the CAT, if you try to measure the volume, it's hard because they're very not solid. So one of the things that I want you to take home from this talk is that the growth of a solid nodule doesn't only mean that they grow in size. It also means that they grow in density. If it looks a little denser, if it develops a solid component, even if the overall size doesn't change, that is growth, and that should be something that you should be looking for. The only definition of Lung-RADS growth that we have right now, it's 1.5 millimeter change size. It doesn't really tell you if it's solid or ground glass or not. So this is something that you should always remember. Changes in density are growth in a subsolid nodule. And the other thing that Lung-RADS sort of addresses is in the category 2, when you look for ground glass nodules, it tells you they slowly grow, but doesn't really tell you what slow is. So again, judgment and clinical judgment and your experience is what it's going to count in this. You're kind of free to do what you think is more appropriate. This is, for example, a nodule that didn't really change in size, but it completely became solid. And you know that's a cancer, but it didn't really change in size. So you need to use a lot of flexibility when you apply your guidelines and say, hey, it doesn't matter if it's like smaller than what I think that what the recommendation is going to say, just get a follow-up CT. You know this is a cancer, you need to act a little bit more aggressive. This is an interesting nodule that we actually had this week shown to us. And we are 3 chest radiologists in the academic division right there. And we emailed a bunch of people because we really didn't know how to categorize this nodule. I mean, some people would say that's kind of ground glass nodule. Some other people say, well, but there is, it's solid around it. But how do you measure that solid component? Sometimes you're just not going to know how to do these things. And we asked, all of us gave different answers on how to categorize this. And sometimes there's not a clear answer, and it's not right or wrong. We all agree on something, though. It looks like something that needs to be taken out. It looks like a cancer. It was a cancer. And there is one thing that was already mentioned now, that you have a good modifier here, the X. And in the STR last month when we were there, they call, like, if something doesn't look right and looks worrisome, just exit and put it at X and tell that's suspicious. And that's your way also of being a clinician and telling that, I know that we don't have a comparison, but this just looks like cancer. We want to pull the trigger on this. So anything that is 3 or 4, if you put an X to it, then it's gonna make you're free to make more aggressive management. And this was an adenocarcinoma. So that's your footnote. Those very tiny little things sometimes are gonna take you to better management. And these are all speculation, a ground glass nodule that doubles its size, lymphadenopathy, but really it's up to you. I mean, your experience is more valuable. One thing is that not all the ground glass nodules are cancer. So this is just an example of someone that had a ground glass nodule. He had prior lung cancer and a pneumonectomy, and it was probably some sort of infection and inflammation, but not all ground glass nodules are cancer. Their monitoring is a little bit difficult. Again, what I say, it's because they're hard to measure, but not only that, they grow very slowly. Their volume doubling time is between 3 to 5 years, not like a solid nodule. So it's hard to pick up changes in 1 year to the next, actually, in this type of nodules. And actually, Lung-RADS has a little bit of an aggressive behavior. Fleischner usually, when we had a ground glass nodule, says get a follow-up in 3 months, just to confirm the persistence. Lung-RADS actually gives you 6 months, because whether or not they're cancers, they usually grow very slowly and they have relatively benign behavior. If they're persistent, so then you jump them back to category 2, which is basically the same as just having a 5mm nodules. So some of us actually feel like it's hard for us just to call something that looks like cancer the same as a 4 or 5mm nodule, but at the moment that's what we have to do. We do know, though, that we learned from lung cancer screening trials that tons of times there are pre-invasive lesions that weren't surveillance for many years. And these patients are going to get scanned technically once a year, so we will be surveilling them. But it's controversial because sometimes we don't know when to pull the trigger, what do you do with them? I mean, this is all the overdiagnosis that came with lung cancer screening. Like, patients are probably going to die with them rather than from them. And we pull the trigger when we see changes. So since they grow very slowly, you should always try to compare it to the CT scan that you have farthest away, not just the prior, because it's going to be hard for you to notice the changes in these nodules since they grow so slowly. And some people feel like they should add a modifier to category 2, just basically saying, hey, this falls within the adenocarcinoma spectrum rather than just a ground glass nodule. But we'll see what future iterations show. And another good point that Dr. Goodman talked about, this was a case that we got last week. It was an outside interpretation. And the patient got a PE study and they saw this 4 millimeter ground glass nodule here. So they recommended a follow-up in 3 months. And we got the repeat CT, and we kind of noticed that if you notice here, there are vessels and there are vessels here, but this is kind of black. So when we see that, we know that that's the minor fissure. And if you go back to your coronal and sagittal reconstructions, you can see there's just like a tiny little thickening along the fissure. That's really not a ground glass nodule. You don't really need to be following this up. So it's very important for you to look at things in different, like at least in one orthogonal plane. If that's flat, I have a mentor that tells me that no self-respecting lung cancer is flat. So these things don't need to be followed up. This is the same. One of these is a scar and one of these is a cancer. And if you're just looking at this axial image, which one will you call which? I mean, they look exactly the same. But you get your axials and you can totally see this is a scar or atelectasis, depending, it's been there for a while. And this has volume. So it's always very important to address the volume, just not your axial images. Even if you're in a rush, you have to do that. A few other things that we encounter. We know that everyone that is getting screened smokes or smoked, and they usually have secretions in their airways. And actually, Lung-RADS talks that everyone with endobronchial nodules should get a follow-up CT in 3 months, which is, if you strictly follow that, you'll get CTs in everyone every 3 months, and that's just not real practice. So I'm going to show you a case of something that we find helpful. This was a woman that had a non-dependent nodule in the right brainstem, and it kind of measured high density, but we had, for some reason, a prior CT, and we knew that was new. So a cancer just usually doesn't grow that fast. We knew that was probably mucus, but it's hard to prove that. If it's non-dependent, you know, it's not your typical layering thing. So we had her actually cough vigorously the same day she was in the hospital, and you can see that's totally gone. So if we didn't do this, this woman would have, so this is just how mucus, you know, if you see air within it, if you see low density, if it's layering, if it's everywhere, you're pretty confident about it. But since we didn't have that, you know, she would have gone home for 3 months thinking that she might have lung cancer. So we find it helpful to have patients cough vigorously before scanning. It's not really a recommendation at this moment, but it's a tip that you might want to talk to your technologist about, because it does help. It might save you some headaches. Another thing about endobronchial lesions, and this is a case that we had, one of our community radiologists picked up, which was great. You can see there is this filling defect here in the bronchus, and you can really pass through this without contrast. It's very easy if you're in a rush. But notice how the borders are convex. And another thing that might tip you off is that distal to that, there were tree in bud nodules. So people with secretions commonly have tree in bud, but if you see an area of tree in bud and it's just that area, just go back and run the airways again proximal to that, because there may be just an endobronchial lesion hiding there. And this was a lung cancer screening baseline, and she picked this up as a non-small cell lung cancer. Another words about people that had lung cancer, it was already mentioned. They usually get 5 years. During 5 years, they get CTs, but then they go back to screening according to the thoracic guidelines. But you know that they go back to screening because they have a 3% risk of having new lung cancer. So they still have the same risk factors if they haven't quit smoking. And the recurrence peak, usually it's between 2 to 3 years. So you might start screening people that had lung cancer in the past. So if you do, just remember that you have a modifier for that. And if you find something in them, it's more likely that you're finding a new cancer, not a metastasis, not a recurrence. That's probably just a new lung cancer. People with prior malignancies are something also that were not addressed on Lung-RADS. And you know, sometimes we get calls and say, hey, a patient had lymphoma or they have breast cancer, they're young, they're considered cured or disease-free, can they get screened? And it's not addressed at the moment, but we think if, just like an 80-year-old or a young person, if they are more likely than not to be alive in the next 5 years, we think it's worth it for them to be screened. But right now we don't have an answer. I think that's all about clinical judgment. And this is the last case that I'm going to show you. This was the, oh no, sorry. This is when you have potentially significant findings on a lung cancer screening CT. Basically, you give it a modifier, an S, but it doesn't really tell you what to do. It says it's as appropriate as considered. So, you know, we can see coronary calcifications, we can see aortic aneurysms, adrenal nodules, thyroid nodules. You're going to see all sorts of stuff. And what is important is that you're consistent, and you're going to see this in lung cancer screening trials. 10% of people had other incidental findings. I think we find more, especially coronary calcifications. Almost all the smokers have them. So we think that you should just be consistent and just try to develop guidelines for your practice. And for the moment, we just recommend to use the ACR white papers that are out, because at least you have some sort of backup, and these were developed by experts, at least in the abdomen findings, in the thyroid findings. And the calcium you can always put in your impression and give it just a mild, moderate, severe sort of thing. And okay, this is the last case, and this was the second lung cancer screening that I read when I was in my fellowship, and we found this huge mass in this person at baseline screening. And it ended up, of course, as you can see there, small cell carcinoma. And it was so hard for us to understand how can someone have such a big mass and don't have any symptoms, because Lung-RADS or lung cancer screening, you're supposed to do in people that are asymptomatic, not symptoms of lung cancer. And we went back and she just had cervicalia, which is, I mean, it's not a symptom that you will attribute to lung cancer. But a lot of the times the clinicians call us and say, hey, I got this patient, there's big smokers, they're kind of feeling bad, can they get lung cancer screening? And I think the most appropriate question to ask them is, do you think they have lung cancer? Because if they do, they should not get a lung cancer screening CT. They should get just a regular non-contrast or contrast CT. But if lung cancer and Lung-RADS were developed to pick up early lung cancers, treatable lung cancers, not cancers that are like this advanced. So take-home points, Lung-RADS should be used, not Fleischner. The growth of a ground-glass nodule should be also a change in attenuation, not only size. Solid and ground-glass nodules behave differently. They don't grow the same. So try to go back as far as you can whenever you have something ground-glass. X is your chance to change your recommendations and be a doctor. You don't really strictly have to follow Lung-RADS. If it doesn't make sense, you can do different things. Check your ground-glass nodules in orthogonal planes. It's going to save you some extra scans. Consider asking the patients to cough before scanning. And in the bronchial lesions, be aware of the convex borders and the segmental tree buds to go back and look at the airways, especially if you're going through them scans very fast. I mean, these are usually technically healthy people. They don't have symptoms. They shouldn't be like messes, chest CTs to read. And don't scan every 3 months people with mucus plugs. That's not really, and you know, these are the first guidelines, and you're supposed to use your judgment. Sometimes there's not a right or wrong answer. It's just about trying to do the best thing for the patient.